Hi everyone, this is Neel Raithatha, consultant audiologist and director of iCLEARscope. Thank you for joining me in my latest video where I use both the iCLEARscope endoscope and also the WAXscope. And it's of a really technically challenging case of a patient in their mid-20s who has what we call a stenotic ear canal, so a narrow ear canal. Not 100% sure as to the underlying cause for his stenotic ear canal, because it can be just anatomical. The patient was born with this narrow ear, or they suffer from chronic ear infections, which is another potential cause. The patient can just remember having a stenotic ear canal since a young age, so he wasn't entirely sure. And they were previously seen by ENT many years ago, who offered this patient what we call a bone-anchored hearing aid, which I'll try and explain during the course of the video if there's enough time. And more recently, well, over the last several years, although they have obviously got hearing loss already in this ear, and it's not, I don't think their hearing loss is specifically due to their narrow ear canal. Now, when you've got a narrow ear canal like this, you're more prone to having a wax impaction, so that might be a secondary cause as a result of their stenotic ear canal. But if you watch right till the end of the video, you'll see an abnormal looking eardrum. So I feel it's not an outer ear issue, it's more of a middle ear issue causing a conductive loss where the sound can't travel through the ear canal or the eardrum before it reaches the organ of hearing. However, this patient was also told that they have damage to their hair cells. When you've got damage to the hair cells are not the hairs that you're seeing in the ear canal, but they're sensory hair cells that are contained within the organ of hearing, the cochlea. So as the sound travels through the ear canal, it hits the eardrum vibrates, and these vibrations are transmitted through three little bones, the middle ear ossicles, and the last bone, which is the smallest bone in the body, also called stapes. When we were at school, we were taught the name stirrup. That's connected to the organ of hearing. So when that stirrup or stapes bone vibrates in response to sound pressure waves, it causes fluid that is contained within the cochlea, the organ of hearing, to travel in waves, if you like. And these waves of fluid then travel over tiny little microscopic hair cells. There's tens of thousands of them in the cochlea. And when these waves travel over these sensory outer hair cells, these hair cells sway side to side and they contract. And when they do, the net effect is that it produces an electrical impulse, which is then sent to the brain, and we perceive that as sound. So if you've got damage to the hair cells, we call that a sensory neural hearing loss, and typically that's a permanent hearing loss. So I wasn't too sure exactly what was going on, but we did some further examinations and tests after the procedure, and this patient has got a conductive loss. I don't think it's due to their stenotic ear canal. It's due to a middle ear abnormality, hence why they were recommended a BAHA. So this patient's been suffering from this wax for many years. They visited many specialists, and because the hearing wasn't that good anyway, they just resigned themselves to the fact, really, just to continue with the wax. But they saw a really nice colleague of mine, not too far, and so my colleague recommended that they visit myself first to have the wax removed, and then once the wax is removed, they can perform a thorough consultation and go through some possible options other than a BAHA. And I'll come on to that, but I just want to talk about the procedure in a bit more detail before I do. So the reason why this procedure is technically challenging is that you would have seen in the midsection of the ear canal, they've got an extremely narrow portion of the ear canal, very stenotic. And for that reason, I wasn't able to use the normal Zollner suction probe. But if we go away from the term Zollner, I'm going to call it a 14 gauge. So it's got an outer diameter of around 2 millimeters and an inner diameter of 1.7. And that's because that suction tip barely fitted in that narrowing. In addition, when I was suctioning, the suction probe was actually causing the canal to collapse, and that can be painful. So all the wax I've removed so far is using a fine end suction probe, which is actually an 18 gauge. Now, ideally, I would want something in between, because the 18 gauge, although you can see it has removed a lot of the wax, and it is extracting this wax that was on the patient's eardrum forwards. It just wasn't powerful enough, but the 14 gauge was too powerful because it was causing the canal to collapse when using the endoscope, and also it could barely fit into that space. So now I've developed my own range. I'm calling it the right ear canal suction tips. They should be available hopefully next week or the week afterwards. And I've got the full range. So they weren't quite ready to be used today because it's all the regulatory stuff that we have to do, which is almost completed now. But we've got kind of sizes in between the 14 gauge. I've got the full range. So with the Birmingham gauge system, the lower the number, the bigger the suction tube. So 14 gauge is the suction tube that we typically use. You can call it a Zollner if you like. Then I've got the 15, 16, 17, 18 and 19. So I've even got a 19 gauge, which is smaller than what I'm using here, the 18 gauge. And we've also got our own suction handles where you attach the suction tips onto, so can't wait until they're released. Now, you can see I'm persevering with the 18 gauge. I've used quite a lot of drops, but when I was suctioning, it was almost pushing it back in. It's hard to get a suction grip because although I did put a lot of drops in, the wax was still a bit firm on the surface, and then you always run the risk of when you're trying to get a suction grip of pushing it in. And it happened on a couple of occasions. So the key here is to almost kiss the surface of the wax and allow that suction power to intensify. So trying to get an airtight seal basically between the suction tip and the wax. And then once you do, you come away really, really slowly, but it just wasn't going to budge. And it's really difficult to use manual instruments here because of this narrowing. So I decided just to try the WAXscope to see if that can help. And the rationale behind that is that with the WAXscope, it will the specular used will help dilate the ear canal. Now, the tip of the specular doesn't go as deep as this patient's narrowing. They're only designed to go about a third of the way into the ear canal, the cartilaginous portion. This narrowing is a bit further than a third. However, it will give some kind of structure and stability to the portion of the ear canal in front of it. So I thought, why not give it a go? And actually it worked to treat. So with the WAXscope, I used a smaller size specular, and it helped to keep the ear canal open whilst I was using the 14 gauge or gauge. Probably used the term in both terms in the course of this video. So, and the reason for that, everyone tells me different things. Everyone says, some people say it's gauge, some say it's gauge. So anyway, and so with the WAXscope, I was able to use the more powerful 14 gauge suction tip without the canal collapsing, and it really, really worked well. And then again, if you stay till the end of the video, I'm going to show you their writers. You can see the difference. Now, some of the tests we did after this wax was removed to confirm what is the underlying cause of this patient hearing loss. First of all, I performed a test called tympanometry, and that's a middle ear function test, and it's where you change the pressure in the ear canal whilst a sound is being played. And essentially, you're measuring how much sound is reflected back out. Now, I'll come back to that. So this is the WAXscope. It's a completely different view, so it's very magnified. So you don't get that field of view with an endoscope. And that's because, like with an ENT operating microscope, the lens is outside of the ear. So even with an ENT microscope, you're going to get a similar view. However, it's helping to keep the ear canal open. And that's the big suction probe now. That's the 14 gauge, which I wasn't able to use with the endoscope. But you can see around the perimeter, the black edge, that's the specular. That's what's trying to keep the ear canal open. And it's going to come through really, really well in a moment. And I'm going to zoom in as well. So with our WAXscope and with the iCLEARscope, with the app that we use, that it's a ClearWax app that we've developed, it's got zoom function. So it's going to work really well in a minute. There we are. I've just zoomed in a little bit more. I'm going to get it in focus. So whilst you're watching me suction this away, yes, going back to the tympanometry, we play sounds into the ear. So normally a low frequency sound. We change the pressure simultaneously, and we measure how much sound is reflected back out of the ear canal. The less sound that's reflected out of the ear, the better the middle ear is working because it's absorbing that sound, and the more sound that's reflected, the less well the middle ear is working because it's reflecting it out of the ear. So in this patient's left ear, there was essentially almost all the sound that we're playing into the patient's ear was being reflected back out of the ear. So that confirms a conductive hearing loss, where the sound is not being able to be transmitted through the middle ear. We then performed a test called tuning forks. So I did it in two ways. We played a sound with the tuning fork, positioned it on the patient's forehead, and I asked them to tell me which side they could hear it, or if it was in the middle, and they could hear it from their worst left ear. So when think about your eardrum like a two-way door. It allows external sounds in, so you can hear them, but it also allows your internal sounds to escape, so you can't hear them. With the tuning fork, when we place it on your forehead, it's vibrating your skull, and these vibrations are transmitted to the organ of hearing. So that's an internal sound. So the fact that this patient heard it louder in their worst ear means that, again, they've got a middle ear problem. The middle ear is not functional, so that internal sound is getting trapped behind the eardrum and is being amplified and heard louder. I then positioned the tuning fork behind the ear on the mastoid bone. Sorry, I'm talking very quickly because I know the video is going to end soon. And then we then positioned the tuning fork in front of the ear, and you should always hear it louder in front compared to the back. And this patient heard it loud at the back. That's the patient's eardrum. You can see it's a second narrowing there. It's an abnormal looking eardrum. They've got an autoatticotomy, so the top part of the ear canal, the scutum bone, is eroded, and you can see the neck of the malleus and the head of the malleus as well. So I'll just gonna explain the tuning forks. So when you place the tuning fork on the bone behind the ear, the sound bypasses the ear canal and it bypasses the middle ear and it enters the organ of hearing directly. And when you position it in front of the ear canal, it travels through your ear canal and your middle ear before it reaches the organ of hearing. And you should always hear it loud in front. If you hear it loud at the back, it means there's a problem with the middle ear. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.